but that's down a little bit from the week before. And our peak, we're down still again quite a bit. Nothing unique about the regional variances right now, which is good. Vaccination, 40 million doses, extraordinary, but there's more to be done. So this is a time to just have that wake-up call, say, what have you been waiting for? Everybody knows been vaccinated, so to those who have not, we encourage you, especially get your children vaccinated as we're heading into school. Our numbers are better than most states, but we never rest on our laurels here. But today I'm here to talk directly to parents. And yes, schools are ready for their children to burst through those doors with eager anticipation of another school year. And what a difference a year makes from where we were announcing our Back to School strategy. I was brand new on the job, but I also knew we had kids going back to school within a matter of days, and so we had to ramp up our efforts immediately. And we had a lot of rules last year. You know, we had social distancing, we had quarantine after exposure, we had test to stay. So there's a lot of rules that parents and teachers and administrators had to be familiar with, and it was confusing, very frustrating, stressful. The unknown, fear of the unknown, because this was the first fall when our expectation was that everybody went back to school. And so because parents, I'm a parent, now a grandparent, we know our primary responsibility is to protect the health of our children. I want parents to know as governor, I share in that responsibility. It is my responsibility to do everything I can to protect your families as well. So I'm grateful that this year we have a different scenario, different landscape, so to speak, and we're expected to be a much, much easier year for parents and for schools. You heard last week that the CDC issued guidance. We've been analyzing the guidance, and they relaxed their guidance with respect through K through 12 schools and early childhood education programs. Here in New York, we want to be fully aligned with the CDC, but we wanted to take a little bit of time to process what that actually meant before we release data. And later today, the Department of Health and the State Education Department will be releasing a letter to schools to reinforce our support for the CDC guidance and to have frequently asked questions, so they will be apprised of everything we expect for this fall. So that information is coming out later today. But the big news is no more quarantining, no more test to stay, and the days of sending an entire classroom home because one person was symptomatic or test positive, those days are over. We've been through that experiment. No longer are we going to be sending kids home, keeping them away from that essential experience of being together in a classroom, because we are now still dealing with the fallout of those decisions made when we had less information and there was concern in classrooms, but we now have 2 years of experience to know that children are safe in classrooms, and when they're not in a classroom and the learning stops, the traditional learning stops, it can be devastating for the well-being of those children. We're seeing it in the mental health challenges we're facing now, suicide rates, depression, real mental health issues that were not there before for many of these children, and that is deeply troubling to us. So we're aligning ourselves with the CDC, we're getting this information out to parents and to schools, and making sure that our children are where they need to be this fall, because we know there's no replacement for in-classroom learning. And we're going to make sure that this year is a very different year. So let's go into some of the guidance so everyone's clear on this. As of last Thursday, August 11th, the CDC is no longer recommending quarantining due to exposure. So let's lay this out. If a student or teacher is exposed, has a close contact who's exposed, and they don't have symptoms, they no longer have to go home. They will stay in school. And the CDC does recommend the wearing of a mask for about 10 days if someone's been exposed. So no more test to stay. What that means, if a classmate tests positive for COVID and your child doesn't have symptoms, your child can stay in school as long as they would wear a mask under those circumstances. That's what we're recommending. So that's good news. If a child does get sick, we still want to make sure that there's a smart approach. And of course, if there's symptoms, you always want to be tested. And students should stay home. Recommend that they stay home for about 5 days and wear a mask as well. And if they have no symptoms after 5 days and test negative, they should go back to school. Let's get them back into school as soon as possible. So that's what they're recommending. That's what we're recommending. And we're no longer recommending, and CDC and Department of Health are aligned with this, no longer recommending the screening testing, which is randomly testing people who have no symptoms. That was important a year ago, before that. But in certain circumstances, schools may want to opt for doing screening testing in high-risk activities, for example. Let's think about a choir where children are close together, a wrestling team. So we'll leave that up to individual schools to make that determination, but it is no longer recommended from the CDC or the Department of Health that there be this random screening either. So now that we've covered that, that is a change. That is how we'll be approaching this school year. We are going to be also talking about our overall fall action plan. And we've been able to identify patterns. And I spoke about this when we gathered in July when I said we're putting together our fall plan, even though it was a beautiful day in July. We're getting closer to that time. So what we've seen in the past is a trend that we cannot lose sight of. You know, the number of cases per 100,000 really went up dramatically in the fall after seeing major declines and stabilization over the summer months. So will that happen again? We don't know. But our policy has always been, for the last year straight, has been to be prepared for the worst. So that is why we're going to continue looking at those patterns and make sure that, you know, while these numbers tend to spike in the fall, the weather gets colder, people congregate more. And this fall, we're really hoping that the doors are open not just to schools, but to offices after Labor Day. We get more people back. I walk the streets of Midtown literally every day, almost 5 days a week. You don't see me, but I see all of you. And I know, I mean, there's a lot of tourists, restaurants are crowded, people are coming back, enjoying our social life, and we'd love to see everybody back, going back in their offices, or at least on a hybrid situation. So we're encouraging the employers who are encouraging that as well. So what we're going to see also then are more people in congregate settings working together in offices. So we're going to be vigilant, we're going to remain prepared, and of course, the best way to do it, sound like a broken record, but that's okay. The music hasn't changed. Get a vaccination. Get a vaccination. And make sure your kids are vaccinated. So again, if you waited to see how it plays out with, you know, your friends, you want to make sure everybody's doing well. We've now had a long enough history to realize that these vaccines are safe. So we launched our Vax to School campaign last week again. It's aimed at increasing COVID vaccination rates among school-age New Yorkers. And again, breaking down barriers to vaccine access. This is something we track and monitor, make sure that there are no disparities, especially in communities of color, for access to vaccines. So we're partnering again this year with community organizations, pop-up vaccination clinics, encouraging families to take advantage of this. And there's the website to check out, the closest site to all of you. So our fall plan that we mentioned before, focus on the schools. We're going to get the test kits out there, though. We have been very good at this. Last November, when Omicron had literally just been identified as a variant, our state sprung into action. And I thank Catherine Garcia and her team for scouring the earth when there was a short supply of test kits. At a time, it was November, December, and we knew we had to make sure that kids got back to school last January. This was a great sense of stress on families. Are the kids going to be able to go back there safely? And we knew that if we had a testing strategy where we can get tests in the hands of every single school, every single student, that we could be successful in getting the kids where they belong. So the strategy again this year is making sure that we have ample supply. We've done a masterful job in terms of amassing more than other states, getting ahead of the game, and to the extent that last winter, other states were asking us. Federal government was talking to us about our supply. We have used it. We've gotten it out. We were able to get kids back to school. This year, we're going to be distributing once again to schools, one test kit per child at the start. But schools can request additional kits. You know, we're in a good position to meet that demand, and that's where we have over 14 million kits in inventory, and we procured another 6 million. So that is a good strategy. Again, best strategy is get vaccinated. Number two is make sure that we have the test kits available. Also, we want to make sure every New Yorker has access to medical assistance and treatment should they contract the virus. Therapeutics are critical. I had to take advantage of them a few months ago, and they work very well, so we make sure that we have access to that so people can call and find out where they can get them, and we'll make sure they're available. So right now, 40% of our pharmacies receive from the federal government their supply of therapeutics, as well as our 44 sites. But there has to be equitable access to this or the system doesn't work. So we have a hotline, as I mentioned, phone number to call. And since we launched the hotline, we've had over 1,700 calls, over 1,100 visits for treatment as a result of people being able to make that phone call, find out where the treatments are available, and make sure that people take advantage of that as well. Threw a lot of information at you. It's important. Parents, it's a very different year. It's a very different year, especially if your kids are vaccinated. We do have test kits. We're trying to just draw down the anxiety associated with sending your children off to school this year, and it is a much better year. I am concerned about the trend, but if we can just regroup in about a month, we'll be able to assess the numbers and see whether or not those trends of the past are no longer, which would be a good dynamic, that we came through the advent of school and people coming indoors more safely. So again, we took a lot of precautions with our fall action plan. We're continuing to roll this out, and look forward to the day when I'll be talking about our winter plan, because maybe we won't need a winter plan. Maybe we'll continue to be in a far better place. But I want to talk to Dr. Bassett now, who's going to give an update on both monkeypox. This is very much top of mind for people, something that we put out the early warning signal about before any other state did, declared a state of emergency before any other state did, and we have 1/4 of all cases are occurring in New York State, the vast majority of which are occurring in New York City. So that is a concern, and we are very fortunate to have a top medical mind focused on this nonstop, and she'll also address the issue of polio in the state of New York. So Dr. Bassett.
Thank you, Governor. As you've said, we are now dealing with a couple of different viruses. Let me just say a few words about polio, a virus which we really never expected to have to contend with. New York State last had a case of paralytic polio diagnosed in 1990, but in June of this year, a young adult was diagnosed with polio in Rockland County. Since that time, we look back at our wastewater samples and also have been monitoring them going forward. And we've identified a related virus in samples from Rockland County beginning in March, right up through July, and also in Orange County. Together, these data suggest that we have a community circulating polio virus that can cause paralysis, and this is a source of great concern, particularly for people who are unvaccinated or undervaccinated. So our message on polio is a simple one. It's get vaccinated. If you have not been vaccinated at all, we want people to get vaccinated. If you're unsure of your vaccine status, please get vaccinated. In Rockland County, Orange County, we are working closely with the health departments to make sure that it's easy to arrange to get a polio vaccine. We have seen no other examples of disease related to polio virus. But this is a virus that is usually asymptomatic when it infects people. The majority of people have no symptoms at all. Only fewer than 1% of people have paralytic symptoms. The last thing I want to confirm the presence of polio is another person with polio. Paralysis from polio is typically permanent. So we are working very hard to get the word out to counties, some of which have vaccination coverage rates in 2-year-olds of just 60%. We want that vaccination rate to go up, and we're trying to make it as easy as possible. It's hard to believe that it was just in May that all of us heard about monkeypox, which we now have the distinction as a country of having the largest number of cases in the world. Within the United States, as the governor has just said, New York State has the most cases, and the vast majority of them, over 90%, are identified in New York City. At the end of July, on July 28th, I declared the increasing rate of monkeypox a imminent threat to public health, and it was followed just right the next day by the governor's declaration of a state of emergency. This was in advance of the national declaration, and just a week or two after the World Health Organization elevated monkeypox to its highest level of risk. And we're continuing to work very hard to address this virus. A principal challenge that we've had with monkeypox has been a shortage of vaccination doses, as all of you have heard repeatedly. But recently, the Federal Drug Administration has issued another emergency use authorization for a dose-sparing strategy, which means that we will be administering just 1/5 the dose of that was previously a single dose, administering it through a different route called intradermal as opposed to subcutaneous. And this strategy allows us just to use 1/5 of the dose that we used previously. The reason that we can use a smaller dose is because the intradermal administration goes into the skin where we have more immunogenicity of the dose. There are more cells there that are active in the immune response. So the data that we have show that the antibody response to this route of administration is equivalent to the previous route, which was subcutaneous. As a result of the FDA guidance, we as a state are going to be transitioning to intradermal administration using this dose-sparing strategy. And we expect to complete that transition by a week from today, August 29th, when we will begin administering first doses and second doses intradermally. And a press release will be going out about this later today. We also are making all of our data publicly available. You can find information on the numbers of cases that we have diagnosed in the rest of state. New York City tracks its own cases. As you can see, we now have nearly 2,800 cases that have been diagnosed outside of the New York City in 22 counties. It may be up a little higher than that now. And the vast majority of these, the 2,800 is statewide. The vast majority of these, we've just passed 200 cases in the rest of state. The vast majority of cases, nearly 2,600, 2,596, as you can see there, have been in New York City. So this continues to be largely concentrated in the greater metropolitan area. About 2/3 of the cases outside of New York City are in Long Island and Westchester, Suffolk, Nassau, and Westchester counties. We also are making publicly available the demographics of people who are diagnosed with monkeypox, including age and race ethnicity. And we just last week began posting, as did New York City, the information on people who have been vaccinated. These data show that we are right to be very concerned about equity in access to vaccination. On August 3rd, we announced a monkeypox vaccine effort designating 1,000 doses, working with the AIDS Institute, a long-standing part of the State Health Department, which has very strong ties with the LGBTQ community, to ensure that we use these community connections and address the deficit of vaccinations, particularly going to black men. We now have over 90 countries that are reporting monkeypox around the globe, and the United States has surpassed 15,000 cases. We have 24 out of our 57 counties outside of New York City reporting cases. And I've said this before, but I think it's worth noting again, that there are 3 parts of this current outbreak that have made it unusual and concerning. One is that we're seeing monkeypox transmitted outside of the areas where it had been endemic in Central and West Africa. 2, we're seeing its clinical presentation in ways that aren't classical. And 3rd, the transmission of monkeypox is occurring overwhelmingly among men who identify as gay, bisexual, or as men who have sex with men. We also have observed that although monkeypox is very rarely fatal, it is extremely unpleasant and painful. So it's important that we continue to give frank advice to New Yorkers about protecting themselves, the people they love, their friends, their community. talk with sexual partners about whether they have a rash or symptoms, and avoid skin-to-skin contact with anyone who has symptoms of monkeypox. Another part of monkeypox that people may not often realize is that you have to have the rash before you can receive a diagnosis. We have greatly expanded access to testing. Our state lab, which was initially the only place where you could get tested for monkeypox, is now only doing about a third of the tests, the commercial labs, and we often see this as we transition to usual ways of care. The commercial labs are now providing the majority of monkeypox testing. Additionally, we're working hard to ensure access to an antiviral drug. The trade name is TPOXX, which can be appropriate for people with very severe symptoms. So again, we are working to expand vaccination access. We are transitioning to dose-sparing regimens using intradermal administration. We expect to continue to get the allocation of doses from the federal government. As you will recall, we were allocated 110,000 doses. We expect to receive that number of doses, although because of dose sparing, this is now reflected in a smaller number of vials. So we'll be making public today the allocation of our next tranche of 3,560 vials, on top of the some 28,000 vials that we've already received. You'll recall that New York State, in recognition of New York City's being a true hot spot for monkeypox, has reallocated some 6,000 doses to New York City. So we have so far had about 21,000 doses that we have been distributing, and about 14,000 of these have already been administered. Others are committed in terms of second dose and additional first doses. So let me just end there with a reminder that these data are made publicly available on our website. People can look for more information on monkeypox at health.ny.gov, and you also can sign up for text messages by texting monkeypox to 81336 or monkeypox ESP for Spanish language text to 813366. We will continue to assist people in identifying places to get vaccinated. I want to thank Governor Hochul for her strong advocacy with the federal administration and all the people at the State Health Department who are working on 3 fronts now to confront some new viruses or viruses that we never expected to see again. Thank you, Governor.
Thank you, Dr. Bassett, particularly for your transparency and providing information very publicly. And that is why we've identified that there are racial disparities, and so we're addressing that with your equity investigation into that. So I thank you for making sure that these are allocated in a way that is appropriate. And also, we are going to continue focusing on our efforts to get more doses from the federal government. As you know, they have promised us a certain allocation, but now, with the administration of being able to take 1 vial and have 5 doses from it, our hope is that we can get the same number of vials and not be limited, and that's not how they see it exactly right now, but we're going to continue those conversations in earnest as a matter of equity and as the epicenter of this in the state of, not just in the state of New York, obviously, but in the United States of America. So with that, if there's any questions further on monkeypox, we'll have Dr. Bassett answer them, or on polio, or any other questions you might have.
Governor, I wanted to ask about the intradermal dose-sparing strategy here. There's been a lot of questions about how effective that is versus the regular strategy. I wanted to sort of understand what new data we have to show that this does work, to kind of allay the fears that are out there that this just isn't as effective.
Right. Dr. Bassett?
Sure. Can I answer from here?
You're welcome. Yeah.
Okay. Thanks for that question. You're right. The initial labeling by the FDA was for sub-Q administration. But we know that administering intradermally is immunogenic. Other vaccines are administered in this way. And we have a study that shows equivalent antibody levels by either method. The reason that we often prefer subcutaneous is that it's simpler operationally. As somebody who's given both types of injections, it's easier to give a sub-Q injection than a intradermal injection. So for the person administering the dose, it's easier to administer than sub-Q than intradermal. But we are having this transition period, as I've mentioned, and we already have begun it. And we're confident that by next Monday we will have been able to ramp up with confidence our competency in intradermal administration. The next is what it means to get this shot. And it's not as pleasant to get an intradermal injection. It can scar. It is more painful. There are more complications at the site. These aren't serious, but they're unpleasant. But, you know, we have been struggling with not having enough doses. And our obligation in public health is always to do the most good for the most people. And intradermal administration will vastly expand our access to a scarce resource. So I hope that's reassuring to anybody who wonders about whether they should receive the intradermal injection. It will be, you know, less pleasant to receive, but it's just as immunogenic.
Does everybody understand the difference between the two, the administration? Okay.
Yeah, no, all right, let me give it a try. I heard that the LA County, which began last Wednesday at administering intradermal as their overall strategy, was using hot dogs to practice giving intradermal injections. So this is within the skin. And when you slide that little needle into a very just under the layer of skin, you raise a bleb. It looks like a little mound is raised in your skin. And that's within the layer of skin. Our skin is a very important organ in fighting against infections, and there are many immune active cells in that layer of skin. And the intradermal, smaller injection of volume is just as immunogenic. Subcutaneous is under the layer of skin, and so that's the difference. If you get an intradermal injection, keep an eye on the bleb. By bleb, I mean that little disc of raised skin. You should have that.
All right, so that's the takeaway from today's press conference. Watch out for the bleb, everybody. And so again, intradermal pinching, making
within the skin.
Subcutaneous is just basically
Right
the regular
under.
shot. You know what you get very quickly.
Yeah.
So I could see the blank looks out there. So but I'm glad we could have a chance.
I'm curious if the federal government's move to basically force you to do this. I mean, would you prefer to stay with the original route if the federal government hadn't said you need to do this to get it?
If we had unlimited supply of vaccinations, I think everybody would have preferred to stay with sub-Q, but that's not the situation that we've been in.
Right.
That has not been our situation from the start. As you all know, from the very beginning, our ability to respond to this outbreak has been predicated on a limited vaccine supply.
Governor, you touched on this, but just maybe you can elaborate in terms of the amount of dosage that we're going to, or the amount of vaccine that we're actually going to have. The federal government is now basically saying do more with what you have, and that doesn't necessarily mean you're going to be getting more.
Because they're dealing with severe supply chain shortages as well. They're not unnecessarily withholding this. They have an allocation. They'd like it to be more. Again, it was a sole source manufacturer from Europe. Other countries are searching for this as well, and that's where we are. So they know that we want more. They know that in their minds, if they were going to give us 110,000 doses, and now we can use one vial for 5 instead of 1, you know, they subtracted down the number of vials. My argument is, give us the same number of vials, and we can really have an effective approach here. But they don't have that luxury right now. But we're continuing to press first in line, my hand is out, saying, what more evidence do you need than the number of cases that we're seeing right here in New York, especially right here in New York City? So we're continuing on that front, but in the meantime, people want to get vaccinated. They're anxious, they're desperate for this, and so that's why this is an interim approach until the supply chain challenges break, and then we'll have unlimited, and then we can go back to even a different way to administer it.
Governor, with back to school right around the corner, and now a child having monkeypox in New York State, what can you share about how that child contracted it? Was it in a home? Was it in a school setting from a relative? And what should parents know about school, daycare settings, about even the transmission?
Again, this is one case, and I'll let Dr. Bassett address that, but we did talk about getting information out, especially in high schools. There could be some vulnerability among populations there. Young people engage in sex as well. And there are, situations where there could be exposure from their own activities. And so we're talking about how to get that information in a very, assertive way to the schools. But that's something that we just started having conversation about. We'd like to have that in place by the time the school year starts. But in terms of how this case was contracted, Dr. Bassett, is there anything you can...
We just are releasing information that this was a minor. And just to, as you've indicated, Governor, the settings in which I think about that a child might be at risk are if gay people have children, and if they have a parent or a caretaker in the household who has monkeypox. We've had very, very few cases diagnosed, however, under a dozen nationally, out of some approaching 15,000 cases, which have overwhelmingly been in young adult men. So the school setting is not a setting in which I am concerned about transmission. I am concerned that schools know what to do if they have somebody who's either been exposed to monkeypox or who has been diagnosed with monkeypox. And as the governor has said, teenagers have sex. Half of teenagers have had sex before they're 18. That's what our data show, whether parents like that or not. That's what our data show. So we expect that we will see cases diagnosed in children related to household exposure, related to their personal behavior, but I do not see the schools as a place where we are going to have to worry about transmission.
Can you give us some indication of how the juvenile is doing? How are they feeling? How are
No,
they
I mean, we're very careful about protecting privacy when there's only one individual. I really can't, I'm not giving you any further information. I do have some data that you may be interested in. Among our cases, this is in the rest of states, so that's just about 200 individuals. 31% have been people who identify as white, 30% as Latino, 17% as Black or African American. In terms of who's been vaccinated, among Blacks, that's 8%, so that's half the proportion of people with cases. Among Latinos, 13%, and among whites, 64%. So as compared to 31% of people diagnosed with monkeypox.
And that's the cases outside the city.
Issue. That's the cases outside of the city. New York City has also published its data. All of us are showing what appears to be an underdiagnosis of monkeypox among Black men. Might be related to many things. I'm concerned about that. And also, we're very concerned, which is why we launched the Vaccine Equity Initiative to work with community-based organizations, that we reach out to people and make sure that they're aware of the opportunity to be vaccinated if they're eligible.
You're talking about easing on COVID restrictions, but you just recently renewed the state's state of emergency when it comes to COVID restrictions. So what is it about the state of emergency do you feel like you can't do without? Oh, yeah.
What I can't do is allow there to be a broader scope of service. What that means is right now, certain individuals, like EMTs, without that scope of service expansion, that they can't administer vaccines. So at a time when we're looking the next month, we're going to be standing up sites, and we're going to need more help. So that's one example. But with respect to the ability to follow different contracting, emergency contracting to amass the supply of test kits. We actually have been following the normal protocols. Even though we have the authority to do otherwise, we have been following the normal protocols since that surge last winter when it was a very desperate situation when everyone was searching for test kits. But I'm going to be looking, we just issued it. What I want to do is recognize that this is our vulnerable time. This is when we've seen, you're lulled into the sense of complacency. See, this is our third year heading into this, third winter, third fall. And I want to just give ourselves another month to assess, whether or not we needed that extra ability to have additional people be able to give vaccines. And that is really how we're primarily using it right now. Otherwise, other procedures are back to normal. But I'm going to look at it closely in another month and looking forward to, not needing that anymore if we don't need those extra workers.
Done legislatively this past legislative session?
This is an executive order, and this just, we renew it month to month. And again, it's related now to just making sure that I have healthcare professionals who otherwise would not be authorized by the state education department. State education makes those rules, and so this gives me as the governor the ability to say, we're still in a health situation, and we need those extra people available. But that may come to an end soon. And when it comes to an end and we don't need it, I'll be very happy to cease the executive order. Probably, we're going to look at it very closely in the next month. Let's just get through the opening of schools. Let's just get through more people coming back to work after Labor Day, and then assess our numbers at the time. I think we're...
Governor, if I could ask on a separate topic, we recently heard from Governor Murphy in New Jersey about his views on congestion pricing and how he would like all drivers told the same way, whether they come through the Holland, Lincoln, or George Washington Bridge. And then he made almost a veiled threat to say he'd hold up business at the Port Authority if that doesn't happen. I wanted to see what your thoughts are on the governor of New Jersey, in essence, threatening the state of New York on this.
I will, as I always have, conduct my conversations with other leaders in privacy to talk about our interests, but also to remind everyone that the process is still fairly early. We just have the traffic mobility study underway and the people that are assessing information. So I don't pay attention to statements. I work things out behind the scenes. I'll get the job done, and we'll do what's best for New Yorkers.